Okay, well, you've probably met Jessica more than once today.
You're all sick of me at this point, is what she's saying.
And then we have Mary Manley, representing Hospice, is going to talk a little bit about palliative care hospice. And I think you all know why we are in this room to discuss various topics regarding building a support network and when it's time to get in-home help, talk about available resources, how to access resources nationally, locally, or online, and of course, Mary with hospice and palliative care. So I'm going to ask Jessica to go first and talk a little bit about, she's got a number of subjects, and then we'll go to Mary, and then we'll have questions at the end, correct? Okay.
Sounds good.
Thank you, Jessica.
And by the way, one of the reasons I have a number of subjects, I just have to share that we had another panelist who was supposed to be with us today, Caryn Utberg. She's a geriatric care manager, and she was called to duty on an urgent client situation. She felt so bad that she was missing this, but between her and me, we covered a lot of different topics, so I'm going to try. I don't really know what she was going to share precisely, but I just want to make sure to touch on those things as well. So thank you for listening to my voice so much today, and now you're going to hear more of it.
She's entertaining, isn't she? Yes.
That's a really nice word for it. So I just want to start out by saying why we're even talking about this, the idea of building a support network. And it kind of touches a little bit on what I shared earlier today, just about keeping these open lines of communication, but it's a lot more than that. It's about how you're in a journey where you have to be a lot more purposeful than you probably ever had to be before about building a support network. And this is what's shared to me from my patients and support group members. You probably went your whole life, you had your friends, you had your coworkers, you had your partner, you had your family members, and it just all kind of comes naturally, and you didn't really have to ask specific things of specific people. And then when you have a chronic progressive disease, then people talk about you need to take care of yourself and go to a support group, and when are you going to hire help? And all of a sudden you have to think, okay, who makes up my support network? Is this sustainable over time? And how can I purposefully acquire more support through this journey? And I think that that's just a really important thing to recognize in yourself, and where are gaps in my support network that I can work to fill, and what will that look like for me? So I wanted to talk about how great support groups are. I know a lot of the people in this room, and I know a lot of you already attend support groups, but I don't know everybody in this room. Maybe raise your hand. Do you attend a support group? Attended? Okay. Are there people who don't attend a support group? Okay. So there's a mix. And we were talking in the other room about how a reason for a lot of people not attending a support group is because there simply might not be one in your area that's specific to these diseases. I mean, MSA is a rare disease to begin with, but so to happen to live in an area where there might be one. Can I ask where you all live? I'm going to put you in Iowa. I don't know the support groups off the top of my head in Iowa. But so I was talking about in the other room about the idea of getting creative. Like if you are interested in a support group, there's not an MSA specific support group in your area. I know a lot of people who will find Parkinson's support groups, knowing as you walk into those that there will be things that you can't relate to, but there will be a lot of things that you can, because there's overlap in at least the basic needs of living with a chronic progressive disease. Some people find just general caregiver support groups, and there might be all different kinds of caregivers of different diseases in those groups, but there again, the idea of taking care of yourself, of changing roles, changing identity, adapting to your home environment, those are going to be across the board with support groups. And then there's great online support groups. CurePSP on their website, they list out all of their online support groups. There's one specific to each disease. There's one specific for care partners, for patients, for adult children. There's a bereavement one as well that's brand new for people if someone's passed. So some people, I mentioned the other group, really like online support groups too. It's a totally different dynamic, but you can be an anonymous person if you want to. A lot of people I find in my clinic setting are kind of hesitant to try a support group because if you've never had to attend one before, you don't really know what that looks like. You think it's a lot of people sitting in a circle sharing their feelings, and it could be like that. But if you're a person who's like, I don't want to talk to a total stranger about my life, I always tell people, try one. Just try it, because the worst that could happen is you lose an hour and a half of your energy and your time, and then you're like, that group is not for me. 9 times out of 10, my patients come back to me and say, I was so surprised at how much I liked it, because it was so validating to know that I'm not alone in this. There are other people out there who get what I'm going through. Or I picked up some really good tips. I learned about a new piece of equipment, a new therapy that I should try. So usually people really like support groups. Every support group is very different in terms of its makeup and its environment. Some are very, very education, presentation focused. Some are very talking focused. Some are a good mix of them. So also just being mindful of what kind of support group fits you the best. Or do you like a group, but you could have suggestions for the facilitator about things that you would like to see in that group to meet your needs. In Chapel Hill, I run a quarterly MSA support group because there wasn't an MSA specific one in the state. There's a atypical Parkinsonism one that just started up in Greensboro. That's all 3 diagnoses, and they're monthly. I do run a monthly PSP and CBD support group, but I had people with MSA coming to that, and while they're still welcome to, I don't know if you've noticed today, they're still very different diseases just in terms of the progression and the main symptoms, and so we decided to split them up. So we have a quarterly MSA support group. We do have people who come from different parts of the state because we only meet 4 times a year. You can come if there's just like one topic once a year that interests you, or one time that you happen to be in the area for a doctor's appointment and you want to meet with some other people. But I also think right now in this room is probably the best. We have our own little support group going on in this room, and I already see like groups of people who I all know, but everyone's meeting each other, and that makes me so happy. So that's what I wanted to share about support groups. Did I miss anything about support groups?
I think you covered it pretty well. Yeah.
Okay. I also wanted to talk about, and this is a really loaded topic that I could give a 2-hour talk on, so it's hard to boil it down to 5 minutes, but the idea of hiring in-home care, or really, let's go broader than that, the idea of respite care and tapping into outside help, professional outside help. That is a huge step for families to take. It overwhelms a lot of families. A lot of families struggle with feeling guilty about that. There's also financial aspects of it that families have to take into consideration. It's a really big step, and then I find that once people get over that hump and tap into outside professional help, they almost always say, I wish I did this sooner. And they always also say that about hospice all the time, too. Yeah. I was thinking about that while you were talking before. Those 2 things, people always are scared to do it and then say, I wish that I did it sooner. So with outside help, I think one big thing, it's scary, the idea of bringing in a stranger into your house, into your comfort zone, and you stepping away as a care partner and entrusting the care and monitoring of your loved one to this person who you just met for the first time or one other time before. There's also a lot of guilt that's often associated with that, of getting stuck in that role, messages we give ourselves like no one can do it like I can do it. Or if I'm not here, something's going to go wrong. Or I'll hire someone, but I'm still going to stay upstairs just in case he needs me. Normally that doesn't really work out because they still call on that person. You don't really get a whole lot of respite time. So I always encourage, if you have in-home care, physically go somewhere else. Take that time to recharge or run errands or what have you with the peace of mind that the person with MSA is being looked after by someone who's trained to look after them. So not only is there that self-care piece, which is such a nebulous kind of term of like, I care for the caregiver, what does that really mean? But sometimes, and I learned this year even as a mother of a 16-month-old son, that if I'm in that role all of the time, it's so easy just to kind of lose my mind a little bit. It's, to get lost in that role and forget my other identities. And sometimes, especially when I was on maternity leave, my husband would come home from work and I'd be like, you take him, I need to go to the mall, and I need to talk to other adults. And I think it's a similar thing. It's not the same thing. I'm not going to pretend like I know what it's like to be in your shoes, but just in terms of getting a way to recharge, stepping out of that role, even if it's just temporary, knowing that everything will still be okay when you come back. But we also so often talk about hiring in-home care for the care partner. But I always like to point out, people don't recognize this a lot, how helpful it is for the person with MSA as well. So I was actually a professional in-home caregiver for many, many years. And I developed great relationships with some of the people who I worked with. And it was more about companionship and socialization for that person, while also being help in the house, if they need meal preparation or light housekeeping or personal care or medication reminders, like yes, all of that too. But we could do things like gardening, playing chess, taking a walk around the park on a nice day, going out to lunch and getting out of the house and having a change of scenery, running errands together. And I looked forward to it as a caregiver, and my clients looked forward to it. And the family, and we just had a really nice dynamic. So it's just a really nice option. It's sort of a win-win for both people if you find the right caregiver. Now, that's another thing that I just have to put a little plug in for, is that you can identify before you hire people what kind of caregiver you would really like. What kind of personality are you looking for? Do you have an age range, a gender, that kind of thing that would maybe make you more comfortable? So then when you start looking, as well as what hours would make most sense for you, as well as what kind of things they can do in your house, so that you're kind of armed with that information when you start reaching out to private caregivers or to agencies to say, this is the kind of caregiver and I'm looking for and what they can do. And if you hire an agency, you have the right, if they assign you a caregiver after you tell them what you want to be matched to, you have the right to then go back to them and say, you know what, I'm just not having great chemistry with this person. Can we try someone else? Here's what I'm looking for. And of course, you have that right for private duty caregivers too. And I say private duty, meaning in this case, people who are not employed by agencies, who might be working kind of on their own, and you might hear about them through friends or religious organizations. A retired nurse, or she took care of her mother who had Alzheimer's and now wants to, help out with someone, or someone who's going to get their CNA and looking for some side work. Those are sort of your private duty caregivers. There's a handout that I had given Jacqueline that I believe is printed out, smattered on your table somewhere. I know you were given a lot of paper today, but as you start doing your fascinating reading, there's a handout that I put in there that says in-home care options and considerations. That goes into this whole thing in a lot more depth about what kind of services they can provide, as well as the differences between private versus agency care, as well as some questions to ask and considerations as you look into that. And then I also just want to share about the option for adult daycare this is this is something that a lot of people are kind of scared off by because it sounds like daycare. It sounds like what you put your kids in, or it's just an odd concept to go to a place with a whole bunch of other people. But there's so many benefits to it as another option for respite. So again, respite being the care partner has a break to do whatever, or they might be working and they just can't be there all the time. But it's huge, huge option for socialization, exercise, engagement for the person with MSA. So these are places you can go sometimes for half days, sometimes for full days. Some people go just a couple times a week. Some people go every weekday. Every situation is different. And they have field trips. They do assigned activities. They have downtime. They have music therapists come in. They do crafts. They do sports. Just a whole host of things. I also just always like to share it's significantly cheaper as a respite option than in-home care is. In the other room, I even broke out my calculator, but I think I remember my numbers. Huh? 480. So what I shared was if you were to hire an agency in North Carolina, but this is sort of everywhere, an agency tends to be about $17 to $25-ish an hour. Now that depends on where you live. If you're in like a more rural area, it might be less expensive. But let's call it $20 an hour. This is where my math comes in, right? Let's say you want to hire them. I made this up for the purposes of just comparison. 8 hours a day, 3 times a week. I busted out my calculator and I figured out that's $480 a week for that care that I just described. Most adult daycare centers range in price from about $45 to $90-ish a day for a full 8-hour day. If you take the higher range of that and you still go 3 days a week, that was $270 a week, I believe, was the math that came out to. So that's $200 less for the same exact amount of care. That just depends. And if you want your respite to be outside in a change of environment or in the comfort of your home, I know a lot of families that will do both because there's benefits to doing both, getting some help in the house as well as adult daycare. So then my idea for the rest of this, because Caryn couldn't be here and she was going to touch on long-term care, geriatric care management, and how to looking into your counties for other resources, but I feel like you all have heard my voice too much. I want to hand it over to Mary to talk about palliative and hospice care, and then hopefully we'll have time that I can share a little bit about what Caryn was going to say. And then we're going to save questions to the end.
Okay, well, I know that when most of us hear the word hospice, it evokes a lot of emotion, most of it not so good, kind of a sense of fear and uncertainty. And a lot of the way we feel about hospice is based upon the fact that we don't know a lot about it. We know that Mrs. Jones went to hospice. That's all we know is she went to hospice. And it sounds like a place that Mrs. Jones went to. And it sounds like a place that she went to die because she never came back. But there's so much more to hospice than that. And I think that, for decades, literally, the same misconceptions have been perpetuated over and over again. So I want to just kind of clarify a few things for you and tell you some of the phenomenal benefits that there are associated with hospice. Hospice is a philosophy of care. It is about quality of life over quantity of life. That doesn't mean that we do anything to shorten a patient's length of life, nor do we do anything to prolong a patient's length of life. Our philosophy is that dying is a part of the living process of life. It's a part of the life process. So our goal is to make our patients and our families comfortable, to help them to achieve their best life now. And so for a lot of people, that means different things. For some people, it may mean that they just want to be surrounded by their families. They want to have those intimate conversations with their loved ones. It may mean they want to take a special trip that they've been planning to do and just never got around to it. Hospice makes those things possible. We help our patients and our families to think about things that a lot of people don't usually think about or don't want to think about. End of life. What do you want your end of life to look like? And we help you to tailor that. It's so empowering to have options at the end of life. So if you were to sit here now and think about what you'd want your last 6 months of life to look like, if you could wave a magic wand and choreograph your own end of life, what would that look like? Well, for most of us, we want to be free of treatments that may or may not work. We want to be free of pain. We don't want our families to be in stress. We want everybody to be able to spend time together, quality time together, to do the things that maybe we had, or talk about the things that maybe we haven't before, and just embrace compassion and dignity and respect. You choose that. You choose that. You make that choice yourselves. We all make that. We can all make that choice. And again, it's so powerful to be able to do that. Hospice empowers you to do that. We help to empower you to do that. So while you can't actually choose, when you're going to pass away, how are you going to pass away exactly, down to the last detail, you can put your preferences in motion. You can establish what you want for your end of life. And I think all of us, I strongly believe that all of us should. What is hospice? Well, I'll tell you what it isn't. Hospice is not a place. A lot of people feel, and we've all felt this way. Well, hospice, maybe it's a place. When you get sick and you're ready to die, you go to this place, this home. While we do have a hospice, a residential facility or residential home, that home is for patients who are at the end of life, very much at the end of life, where their prognosis is measured in maybe weeks as opposed to months. But hospice can be provided in any setting that a patient calls home. That can be, and most of our patients are in their own homes. It can be your own home. It can be assisted living, skilled nursing facility. We've provided care in prisons, in a homeless shelter. So wherever you call home or your loved one calls home, that's where we provide services. And we bring everything that you need to you, as opposed to you having to go out to seek services and to find those services. So if you were to choose hospice, hospice is a Medicare benefit. Medicare, Medicaid, and most veteran VA programs or VA insurance programs cover hospice at 100%. So that means no out-of-pocket money for you whatsoever. That includes an interdisciplinary team. So you would have a robust array of services that would come to you. You'd be assigned we have a medical director who would oversee your care, a physician, who has to basically sign off and say, yes, this patient, if the disease process takes its normal course, this patient will pass away in 6 months or less. That doesn't mean that you're going to necessarily die in 6 months, but that's just a frame of reference. Sometimes patients get better and they graduate from hospice. But that's what the physician's role is, to oversee the care plan and to prognosticate your life expectancy or a life expectancy. In addition to physician, you also have a nurse case manager who also comes into the home. He does a full assessment and initiates hospice services. Your nurse will be kind of the eyes and ears for the physician, serving as a liaison, identifying symptoms before they're exacerbated or become a really big deal. Somebody that you can call if you get into crisis. Rather than dialing 911, your nurse would be the person that you call, and you get somebody on that phone 24 hours a day, 7 days a week, every day. If it's something that we can triage over the phone, we will do so, but if it's not, then we will dispatch a nurse who will be at your place of residence within 1 hour. And the closer you are to our office, of course, it can be 15 minutes. But typically, the way that we do our territories, we try to make sure that we're not too ambitious with the territory that we can cover, because we want to be able to get to our patients in a small amount of time. Also, in addition to your nurse and your physician, you'll have a CNA. The aide is a very important component in the entire care process, because the CNA provides very intimate care. And typically our patients begin to really trust their CNAs, and they will tell the CNA things that maybe they haven't told their physician, or maybe they haven't told their nurse. And typically that CNA can be in there from 1 day to 7 days a week, just depending on what your preferences are, what your needs are. You can tailor that. Under some programs, the services, they don't want to come out as much. You know, the less they come out, the more money they make. With us, it's the opposite. We want to come out as much as we possibly can. We're going to get paid a per diem. So every hospice gets paid the same way. But our goal is to provide the maximum amount of care, of quality care that you need. In addition to that, you'll have a social worker who will help with emotional support. The social worker is excellent in is an excellent tool for identifying resources that maybe you are lacking in the home. Support systems, it can be, again, I said earlier, you'd be surprised how many homes we go into where there may not be sufficient food. Well, you know, well-being, food is a huge component of well-being. So if you're lacking that, then it's our social worker's job to help connect you with resources for those things. Connect you if there are issues with money or electricity, then we can help you to navigate the system and get the resources that you need. So that's a very important component of our overall care plan. We also provide a chaplain. You don't have to be of any religious affiliation whatsoever. You don't even have to have an affiliation to take advantage of our chaplain services. The chaplain is there a lot of times just to be that sounding board, somebody that helps you think about the future and what you expect to happen in the end, or what would you like to happen at the end, or to help facilitate conversations between you and somebody that you may, or a loved one that you may not have talked to in a while, and help to mend fences. And so it's a spiritual thing as opposed to a religious thing. So, and one of the most important components of hospice is the fact that under the Medicare benefit, under the hospice benefit, I should say, everything that you need that's related to your hospice diagnosis is provided, from medications to equipment needs, hospital beds, wheelchairs, walkers, bedside commodes. Everything that you need related to your hospice diagnosis is provided for you at 100%. No copays. Now, certain private insurance plans, I can't speak to those because they vary. Some of them do have a copay, but by and large, most plans do cover hospice with very little out of pocket for the patient and the patient's family. So when I talk about hospice, you have to understand when I talk about our services to hospice, the services of hospice, we are treating the patient and the family as a unit. So it's not just, it's equally as important for us to provide for the caregiver and the family unit as it is for the patient. So when we're coming in, we're teaching the family how to take care of the patient. We're helping the family members to have respite themselves. We have a very robust volunteer support and network. In our agency, and most agencies, all hospice agencies are required to have volunteers, but we have a very significant group of volunteers that can come in just because the caregivers typically forget about themselves. They're so inundated with their day-to-day routine that sometimes they forget, wow, I really do need to just get out and get my hair done. I need to go buy groceries, but I can't leave. That's what the volunteers are here for. Just to come over and spend 2 or 3 hours a day, as often as you need, just to spend time while you take care of yourself. If it means nothing but just to go out to the park and read a book. That's what our volunteers are there for. We can provide things like aromatherapy, music therapy. So not all of what we do is pharmacological. We can do some things like healing touch, pet therapy. So those are all things that are included under the hospice benefit. Now, we talk about hospice, and sometimes you'll hear hospice and you'll hear it referred to as palliative care. They're two different things, and even physicians sometimes use the terms interchangeably. But palliative care is one step before you get to hospice care. If you've been diagnosed with a serious or life-limiting illness, then palliative care is there to help you to navigate the diagnosis, to understand the diagnosis. We're there to help you to reconcile your medications, to have those conversations about care goals. What do you want to happen? Let's start planning for the future. We know that you've got this diagnosis. Excuse me. We know that you've got this diagnosis. So let's talk about this. What do you want from this? How do you want to proceed? Don't we need to go ahead and get some advanced directives in place, which is a really important component. You want to have your living will. You want to be able to talk about who your decision-making committee is going to be if you're unable to speak for yourself. So these are all of the things that not only our hospice social workers do, but the palliative social worker will do as well. So we're making sure that you understand the disease process and you're able to navigate that. So as your disease continues to progress, then it's more of a logical transition from palliative to hospice. And it's not that shock because you're already expecting it. We've already had those conversations. You already understand that not a lot's going to change, just the care that is going to be more intensive once you get to hospice. So, we do all that we can do to provide you with the best quality of life now. I mean, there have been times when we had one family, one patient was going to accompany his granddaughter to her senior prom, but his health took a turn for the worse and he was unable to go. He was confined to a hospital bed. Well, how about we brought the prom to him? His granddaughter dressed in her prom dress, and we had the prom there at the hospice home. Now, the hospice home is, as I mentioned before, it's a really viable option for patients who are at the very end of life. I know when my mom passed away, we wanted mom at home. At least we thought we wanted mom at home, but I realized as an only child that I couldn't provide the quality of care that she needed. I tried, but I really couldn't do all that I felt that she needed. So because she was so close to dying, we did have her transitioned to the hospice home where she got around-the-clock care. And I could focus on being her daughter. I could sit there with her. Nurses, aides are in and out, the doctors, social worker, all the services that she could have gotten at home, she got right there in the hospice home. And they made it comfortable for me. I could sleep there, I could shower there, everything that I need. So typically the hospice home is at the very end of life, or if you're in the home and the patient's symptoms can't be managed in the home. Sometimes we'll need to put you, as opposed to sending you to the hospital, we'll bring you to the hospice home where there's around-the-clock care. Everything that we need is there. We get the symptoms back under control, however long it takes, and then you can go back home. So the hospice home does serve a real benefit, and then a part of the hospice benefit as well, and I'm going to wrap up, is that we provide respite. So patients are allowed to hospice will provide for a patient to go to maybe a skilled nursing facility or assisted living or come to the hospice home for about 5 days at a time if the family members want to go and have a vacation or they want to go to a graduation or they've got some plans. So we will take care of the patient for 5 days at the hospice home or in another setting. So just to take the stigma away, there's a lot that we can do to support families, to support our families. And so, as life does, it does happen. Just want you to consider that and keep that as an option, a very viable option for end of life. And that's for everybody, for all of us.
Thank you, Mary.
Excellent.
Jessica, did you want to address a couple of other subjects?
In the interest of time, because I also want to be able to have a dialogue here if people have questions or want to share anything with each other, but because Caryn's not here, I'm going to try to boil what she was going to share down into 3 main things, just also in terms of further building your support network. So one is long-term care facilities. A lot of times we don't think about this as an option because we all, in an ideal scenario, want to age in place in the home. And for many, many people, that is possible. But we also recognize that for some people, for whatever reason, it can be helpful to consider moving to a facility. A lot of times, my families will share with me, I promised him that I was going to keep him at home. And they might say that at the beginning of this journey or the middle of it, not really knowing what this could look like as the years go on. And sometimes it's good to check in and say, is this sustainable? Like what you were saying, am I able to provide all the best care with what we have right now? And for some people, it can actually be really helpful to consider moving to a facility, whether that's assisted living, if that's an appropriate level of care, versus skilled nursing facility. And I think it's really important to understand the difference between all these different things, like what's a continuing care retirement community versus independent living versus assisted living versus skilled nursing. They're kind of confusing. But to find one that's right for you, for your needs, especially considering them over time. A lot of people will say, I don't want to go to a nursing home, so they move to an assisted living home. But if you know the kind of disease that this person has, will assisted living always be appropriate? We want to try to minimize as many moves as possible, because moves are really hard, physically and emotionally, for families. So maybe sometimes it's good to move to a skilled nursing facility, even though you might not need it fully right now, or it's not ideal, because they'll be there to support you as the disease progresses and those kind of skilled nursing needs come up. I also just always like to share that a lot of families tell me the silver lining that they discover when someone moves to a facility, and Jocelyn even kind of touched on this earlier, and you touched on this with the hospice house, that once someone moves to a facility, the care is on the professionals there to provide the care, and then you as the family, as the care partner, can just enjoy the quality of time being that person's daughter, that person's wife, whatever relationship you have. And so, because it really takes, that role shift happens again where you can just focus on quality of time. That's a really nice silver lining to that I think a lot of people aren't aware of. Consider when you try to think about with a progressive disease, down the road, will something make sense? You can consider the options financially, legally, practically. So if you really want to try to stay in the home, or at least as long as possible, what will that mean for you? Do you need to set up your house to accommodate walkers, wheelchairs, other kinds of durable medical equipment? Is the house space itself safe? Do you have to go up and down major stairs or 2 stairs to get into the house? And will that be an issue? Can you maneuver someone easily inside of a cramped bathroom or with your particular shower? So it could be really helpful to have an occupational therapist come in and do an in-home safety evaluation to say, here's some strategies and equipment that you can change in your house that will help improve safety and independence now and down the road. There's also some companies, I know all of our exhibitors left, but I don't know if any of you got to talk to Joe Norwood. He was sitting sort of over there. He has a company called Manor House Renovations, I think. He's worked with a bunch of our families. There's contractors who do this all around who are certified, and what's it called? Certified Aging in Place. It's a special certification where it's contractors who are you specifically hire to do, that are for people with disabilities and aging. So they'll come in and they'll tell you how to put in ramps and certain special kinds of grab bars, widen doorways, lower non-electrical outlets, light switches so that people who are in wheelchairs can reach them, changing light in the house if you have visual impairments. So all of that, and do I need outside care, and how much does that cost, and how much will I need? That versus the cost and logistics of moving to a facility, I think it's really important to be educated on what those 2 different options look like so you can make informed decisions about that. And then my last little thing that I wanted to share about Caryn, because I want to give us 15 minutes for questions. All of what we've talked about today across the whole course of the day, but especially when it comes to all these resources to build your network, it can be really hard to navigate all of this alone. Not even just alone, but it's kind of overwhelming amount of information, and you're like, where do I go from here? How do I find someone who makes, a contractor in my area who will do aging in place? How do I know what are a few good in-home care agencies? What's a reputable hospice? How to navigate all of those decisions. If you are a patient, I know this is a local thing, of Duke or UNC or Cone Health, All 3 of those have clinical social workers specifically in movement disorders. If you go somewhere else, you can find out if your neurology clinic has a social worker. Social workers are trained to help you navigate all these decisions and connect to community resources. If your clinic, wherever you go, does not have a clinical social worker, because many outpatient places do not, if you tap into palliative care has social workers. Most counties will have something, they're all called different names, but they're all funded federally that gets spread out statewide, county to county, so all their services look a little different. But things either called area agencies on aging, departments on aging, councils on aging. Sometimes all these things are even employed within a senior center in your community. Most of them, if they don't have a social worker, most of them at least have things that are called, they're all called different things, like a caregiver support specialist or a resource specialist, and they can help tap you into these kinds of resources in your community. And then the last thing, and this is me sort of representing Caryn here for a second. So Caryn, who was supposed to be on our panel, she is what's called a care manager or a geriatric care manager. They're called geriatric care managers most of the time, but I'm always hesitant to say that because a lot of people with these diseases are on the younger side and might not identify as geriatric, but they can still be really helpful to you regardless of age. But what geriatric care managers do, they are private people who you can hire and pay to help you navigate the healthcare system, the long-term care system. The whole reason Caryn had to leave today is because she's been working with this one client for a really long time, because I think she was saying his kids live in all different states and there's no local care partner. And so she had to help arrange in-home care services and then hospice and then to communicate, to be like a local point person between different family members and the healthcare system. But even if you have a local care partner, geriatric care managers can be really helpful if you're like, I don't even know where to start. I need someone to advocate for me if I go in the hospital, or as a care partner, I am too overwhelmed with navigating what agency is going to come in and when and blah, blah, blah. So it can be really helpful to what? Oh, okay. That's okay. So they're really good resources as well, geriatric care managers. And those are sort of the big 3 things that Caryn wanted to share as far as tapping into other resources to build your support network. Is there anything from the former care partner perspective that you would like to contribute, or as the moderator to ask us that we didn't cover, or do you just want to open it up?
You covered a lot of it, and I would like to say that I wish I had known everything I know now then. This was back in 2004, 5, and then I did that journey alone for a long time, and then I started learning, and it was through the support group that I started realizing that I needed help and how to get this resources. Everything you've touched on, you're very fortunate to be here. We're so happy that you considered coming, because all this information is a lot of it, but somewhere along the line, it's going to kick in if it hasn't kicked in already. But you need to do something to help yourself. Are there any specific questions about anything that Mary or Jessica, or even Jessica has covered today, not even necessarily during this session, and of course Mary regarding hospice? How many of you have heard of hospice, palliative care? Good. So you're not afraid. You're not like, this is what happened, in the early days. So this is a blessing in many ways. Okay, so.
Well, I just want to interject. My husband has PSP. I need to hear a volunteer, and that's why I'm here tonight. Although, can you hear me? My response. Oh, sorry. Anyhow, my husband had PSP, and a little different than MSA, what you're here for. But talking about a support group, I'm from around St. Louis area, and there was a lady who started a group it's called the ABC Brigade. She had a stroke, and she wanted to get people together that had gone through a stroke and mainly had aphasia, speaking problems. And so we started with that group. It met once a week for an hour and a half. The people with the aphasia, which were mostly stroke people. My husband John was the only PSP person there. And he could talk some when we went there. And the interesting part is they would go in their group and caregivers would go in their group. And sometimes we'd hear them laughing because they, as being an aphasia person, was in a room full of people the same as them. If a word didn't come to them, somebody else could help, you know. And when John started, he could talk. But afterwards, when he couldn't talk anymore, they knew he liked to travel. They'd talk about travel, their kids, their grandkids, food, you name it. And they could keep him included in the conversation. And the funny part of it was, when he couldn't talk, it was either a thumbs up for yes or thumbs down. Most of the time it was gentle, but if he meant business, it was, you know. But as a caregiver, I was in this group, and we met, like I said, every week for an hour and a half. For about 7 years we did this. And they helped me through so many things. We laughed together, we cried together, we talked about caregiving, we talked about anything. But I know my sister-in-law, my husband's sister, had told me about an adult daycare center, and I'm like, oh, I can't do that, you know. Nobody can do it better than me, yeah. Anyhow, so I talked to him about it, and he was ready to go do it. So I brought him, and I only brought him a few hours a week, but he always wanted to go on Friday mornings, because on Friday mornings, they would take the groups, and the men would have their own group. And it was so interesting, because they'd have their own group, they'd sit in a room together, and they'd just talk what men would talk about. Whether it was clear or not, they could get across to each other. So I guess what I want to impress on you is that, from my standpoint of view, a support group, in fact, my husband died January of 2017. I still go back and visit this group, and actually I'm working with them. I live, as I call it, Mississippi River separates Illinois from St. Louis. So a lot of people in Illinois, where I actually live, don't want to cross the creek, as I call it. So I'm working with the lady that started the ABC Brigade to try and get it over to Illinois, because I saw how much that support group helped.
That's wonderful. Thank you for sharing that. That's just very important. One of the questions I had is, did you address how palliative care is funded, and did we cover caregiving services, how one would pay for that if they couldn't afford it?
Well, I did not touch. I touched on how hospice is paid for, but palliative is a little bit different, and it varies from agency to agency. With our agency, for example, our palliative services consist of a nurse practitioner and a social worker. And when the nurse practitioner visits, which is about once a month, once every other month, unless there's a greater need, it's billed much like when you go to a specialist, like a cardiologist. There's a copay, whatever your copay would be for that specialist, that's what your copay would be for the nurse practitioner's visit. So let's say it's $30, $35, and then your insurance or Medicare would pick up the rest. Depending on the plan, it varies. Some insurance providers provide very robust reimbursements for palliative, and some not so much. So it would just depend on your plan. Is there anything else?
For caregivers services, in-home caregiver services, if you can't afford, which many people can't, they're spending a lot of their resources on the care of their loved one.
The respite grant, I did not say that.
Yes.
Thank you.
So basically, like CurePSP now has what is known as a respite grant, and quarterly we accept applications. That's reviewed by a committee. Clients are selected. We have a limited budget that is funded by a very generous donor. But we have to be careful about not spending that out over a year and spreading it out amongst people. We've awarded over a year or two, I think, 20 respite grants all over the United States, not in any one particular area. Long story short, so if you get that grant, then Griswold, if they're in the area, would provide services to you based on what your needs are.
Beyond just Griswold, too,
Right.
I understand.
We now cover, right, because there are people in rural areas, and Griswold doesn't have an office there, but it's up to the grantee to provide Joanna with 3 names of 1 to 3 service-oriented companies like Griswold, and then she vets them, and then the process would start. But they would come into your home, and the caregiver is really responsible for just identifying, what do you want your program to be with them? You know, do you want it strictly for care of your loved one? Do you want them to clean your house, do your laundry? What is it that you want? And most of it is for respite relief, so the caregiver can get out of the house. There are also other organizations, because when my late husband was alive, and I reached out for help, the Alzheimer's organization and the FTD organization recognized PSP. They did all neurodegenerative progressive diseases. So I don't know if they still do that, but one gave me $700, the other one gave me $500. That was a lot of money for me at the time because it allowed me to get away for a couple of hours a day to go to Pilates or to go shopping or run my errands usually. But the thing is that there are services out there that will help you get that relief. So please don't be shy. You really have to be proactive, as you all probably already know. I don't need to be telling you. I can see how proactive you've already been. So it's a tough journey for both you and your loved one. And I know for kids, it's like, whoa, what can I do? So
that reminds me of something else I didn't say, that every county, like I mentioned, that every county has different service funding with what services they can provide, but most counties have something called either respite or in-home aid services. Depending on how much funding they have at a time, there could be waiting lists, but a lot of times this will look like about 2 to 3 hours a week. It's not a lot, but it's, you know, any little bit counts of free in-home aid services. Some counties also have respite vouchers. Usually they're about $500 that you can use towards any of this respite care that we're talking about. So a lot of times for families, when it comes to building support networks, or at least with professional in-home care, it's work. I get that. I acknowledge that. But it's a lot of cobbling together all of these different resources so that you can really feel that this is a supported, sustainable care situation for both of you.
I think we're out of time. If there's anything of importance, Jessica should be here for a little while, and Mary. But let's give them a hand for taking the time out today to share with us. Thank you very much.